So the idea behind the talk tonight is, you injure your knee, you have an ACL injury, or you suspect you have an ACL injury, what do you do? Okay, so they sort of shop work the name, and it's the roadmap for recovery from ACL injury, or the name that I wanted to call it. See if this works. Yep. So you tore your ACL and now life is over, okay? Or really is it? Because nowadays we have lots of good options on what to do. Okay, so here's one typical injury. It may not always be as dramatic as that. All right, so first things, the basics. This is my daughter you might have seen out there. She's just turned 15 months. And she's going to sort of help us along with our talk here, okay? So first things first, the basics of your ACL. So the anatomy of the knee. Okay, so where's your ACL live and what does it do? All right, your ACL lives inside the knee. It goes from the back of the femur, which is your thigh bone, to the front of the tibia, which is your leg bone, okay? It connects the thigh to the leg. And classic thinking was the ACL keeps your tibia from going forward. It keeps, front to back motion of your knee fairly stable. And that's how they used to fix it once upon a time, is to keep your knee from going forward. And there's been a little bit of development on this where now they show that it actually really controls a lot of rotation about the knee as well. So if you don't account for this, you're not going to really recreate the mechanics of the ACL if you don't put in a little bit of a rotation to it as well. All right. This is just another view sort of showing it goes from the back of the femur. Is this, I don't know if there's a laser pointer on. There's a laser pointer on here?
Red spot.
So back of the femur up here, bottom of the tibia or front of the tibia right there. And here, this is a very lovely graphic of it being torn and nice and red. Sorry, this is coming across a little bit blurry on the screen right here. So that's where your ACL lives, and that's where your ACL does. Keeps the kneecap, keeps the tibia from going forward, keeps it from rotating. So what happened if you were skiing or if you're doing something? This talk is going to be a little skewed towards skiing because we're in season for it. So you're out skiing, having a lovely day, your knee twists, you feel a pop, something like that, something doesn't feel quite right in the knee anymore. What happened? What did you do? All right. Most ACL injuries with skiing are non-contact injuries. So it's not the snowboarder that ran into you, it's you twisted or did something and there's usually no one around for you to blame. All right, which is not fun. So the idea behind an ACL injury, again, here's your femur, this is your tibia, this is a view from the side, your kneecap's right there, so this is the front and that's the back. And when we look at these, we look at the mechanical vectors of the knee. So the knee line's up here and your patellar tendon runs over here, and that actually doesn't just run straight up and down, but it has a little bit of forward force in it as well. So if you have a injury where you tense your quad, it'll actually pull your kneecap a little forward and start to stress that ACL. And here's another view way of looking at it. Again, this is kind of showing up a little bit blurry, but the person on the left has got good mechanics where they're landing straight up and down. The person on the right is landing with their leg a little bit out in front, and you can see how that tendon is going to start to pull that knee or pull that tibia forward a little bit, and that starts to stress your ligament out, okay, and put it under tension, which is not where your ligaments want to be. Okay, here's a little bit more of a close-up. Landing straight up and down, your knee's very level to the ground, everything stays in place. When you start to have your leg out in front, now there's a little bit of an angle and your tibia starts to slide forward, and again, as your ACL gets stretched, it puts it at risk. So this is a safe position, and this is more provocative or dangerous position for your leg to be in. All right, so here's a video. This is Tommy Biesmeyer, one of the U.S. ski team athletes. This is back in 2014 when he had a left knee ACL injury. So we can play the clip, please. So he's coming down. His left leg is his downhill leg right here. And maybe we'll here, try video again. Here we go. So you'll watch his downhill left leg. And it's very, very quick when this happens, so we broke it down a little bit. Maybe. So as he comes around on his left side, you can see his left ski here. all right? And he's leaning back a little bit. And as he goes through, he starts to lean back a little bit more. And then he's all the way in the back seat right here. And you can see where his ski, the front of the ski is off the snow, the back of the ski is buried in the snow. And that's going to be important in just a minute. We'll point out how this works. All right, so mechanism of ACL injury. This is very heavily studied, especially in skiers. And here are several different pictures of someone doing the same thing that Tommy was doing, where they're in the back of the back seat of the ski, and the tail is in the snow. All right, so here's a video, here's it broken down, and here's a computer rendition. Same idea of this back ski in the snow, and it puts a force on the snow. And when we look at this a little bit closer, if you put a force on something, there's going to be an equal and opposite force back. So if you put force on the ground or on the snow is going to push back. So you can imagine if the tail of your ski is pushing into the snow or the ground reaction force is going to push up, and that rotates that ski. Okay, and so quite often if someone has an injury, their ski binding didn't release. You can imagine if you're a US skier, how much the din on their skis is cranked up. Those skis don't come off. All right, so that twisting mechanism is really going to torque on your knee. So that's been studied pretty extensively, that if your bindings don't release, you could be in pretty significant trouble with that. They've also noticed what's the more dangerous position, if your knee's all the way straight or if it's all the way bent. And they've actually, at the extreme of either position, that is not where you want your leg to be. You want your leg to be bent somewhere in the middle, but if you're fully straight or fully bent, you're at risk for something bad happening to your leg. All right, this is a study that was done back in 1986, and I really just include this because I thought the pictures were pretty good. These are just drawings, but it shows a good thing where this guy's leg is all the way straight, injury to the ACL. You start bending, injury to the ACL. So this has been known for a long period of time. The trick really is, what do you do about it and how do you manage these injuries? All right, here's another video. This is Lindsey Vonn back in 2013 at the World Championships. We can play this clip as well.
Lindsey Vonn trying to find the perfect grip and trying to chase down Tina Maze. Redefine the season that Maze is having by saying, I wasn't there when you took over the overall race.
What a rivalry they have. She's going to know that Tina Maze is in the lead, but this is the woman here with the most Super G wins of any woman in history. And 50
So you can see she starts getting a little back, but she's hanging on.
So many traps in this course with the conditions. On right now, 400s to work with.
Beautiful set of turns there. Were they too perfect again in Super G? Skipping down so a little bit low there, but back in her tuck so well.
And now has dropped back. Oh! Over the top. And she is down heavily. Lindsey Vonn.
So it's pretty quick, but she lands in the back. That back tail catches again, and it just rotates around. So just to give you an idea how fast these things happen, okay? Sorry, that's a little bit graphic, but we're done with those videos. So you were skiing, you have a nice day, you felt a pop, the knee's not feeling well. Now what do you do about this? All right, that's the big question now. So this is where we look at the academy, which is basically where all orthopedics goes to study and do what we need to learn. And there's a lot of guidelines we have regarding, someone comes in with a story along those lines, what do you do about it, okay? So first thing you always want to do is get the history. What happened? Where were you? You know, those sorts of things. Where does it hurt? And then the next thing is, you know, where do you go from there, okay? So there's multiple recommendations that they have, and they're strong, moderate, and not so encouraged recommendations that they have. And we'll go over a lot of these as we go along, all right? So first thing is, how do you know, is when we brought Lakey back and the cat did not know what the heck she was. So how do you know you tore the ACL? Okay, there's multiple exams you can do. The first thing is the anterior drawer, where you just take the tibia and you pull it forward. The ACL resists the tibia going forward, so if the tibia starts going forward pretty freely, you know the ACL is probably not doing its job. The problem with this is that if the knee's bent to 90 degrees, it can be a little bit stiff, and so that may not always give you a good exam. Another way of doing it is not bending it all the way to 90, but really a little bit more 20, 30 degrees, and try flexing it or try bringing the tibia forward that way, and that's called a Ligament. A little bit of a more sensitive exam, so you're more likely to pick up an ACL injury with this exam. Another one is called the pivot shift, and this is when you actually, the knee pops out of place and back in place. So you can imagine it's not very comfortable to do this in the exam room. This is typically something we'll do in surgery beforehand to confirm if the ACL is out or not. Just one more tool that we can use. So not as useful in the office, but much more useful in the OR. And this is to give you an idea of how sensitive, which is how likely it is to pick it up, and how specific and how reasonable it is to suspect an injury if this is a positive test, okay? So you can imagine the pivot shift, pretty painful, so we don't do it very well in the office, but when they're asleep in the OR under anesthesia, much more effective to use. So again, 38% for the Ligament there. All right, so next thing, if you have a suspicion, the history points you towards an ACL injury, the exam points you towards an ACL injury, get an MRI, and this is recommended by the academy to check this out. So here's what an MRI looks like. The one on the left, this is a normal MRI. Again, this is a view from the side, femur, tibia, patella, or kneecap right there. And here's your ACL. It runs from the back of the femur, front of the tibia. Nice, solid, dark line. Over here on the right, this is actually one of my patients from 2 years ago. ACL, you don't see it anymore. Not there. So that's a torn ACL. Yes?
Older injury?
For this guy? This one? That was a new injury. This is a T1 MRI, and if there's some certain things that you'll see with a new injury on the T2s, they just don't show the anatomy quite as well, but they show a lot more inflammation in there. I didn't include those MRIs. So you can always find fun stuff on the web, like how to assess your own MRI ACL tear, which I thought was fun, which 85% of the time, get it right 100% of the time. You may want to avoid stuff like that, okay? So looking up stuff online, not always recommended there, all right? So you had the exam, you got an MRI, your ACL is out, now what do you do? Do you really need to have surgery on this? The short answer is no, you do not. All right, isolated ACL injuries do not mean your leg is falling off. It does not mean it needs an amputation. Lots of people have ACL tears who do not get them fixed, and they do just well, or just fine. Okay, so again, academy recommendations typically do recommend having surgery if you're under the age of 35 and you're an active individual. Across the board, blanket statement: get your ACL fixed, okay, or taken care of. So what do you do if you're not under the age of 35, okay? And that's where a lot of topic of conversation's gone. Don't be an ageist, okay? And so they've done studies, what if you're not under 35, what if you're over 40? And they've shown by and large that people who are older than 35 do very, very well with having their ACLs reconstructed. People are much more active nowadays. People are skiing in their 70s and 80s. And so saying to someone, oh, you're too young or too old to have a surgery, that's by and large forgotten now. The oldest ACL I've personally done, I've done a couple 68-year-olds. People have done 70-year-old patients. So, and they do actually do very, very well. So the idea of, oh, this is a young person surgery is really out the window nowadays. Here's a little bit of a guideline on what do you do, when do you fix and when do you not. And the whole point behind this, and again, it's a little bit blurry to read, and I'm going to skip ahead to the next one. What we really look at is how is the overall health of the knee. So if you have an ACL tear, but your knee overall looks very healthy, on this side you have very good joint space, your knee looks like it moves well, good idea to get it fixed. If the rest of your knee has a lot of arthritis, you don't have a lot of cushion in there anymore, so it looks something a little bit more on the right where you got this bone-on-bone arthritis there, maybe a little bit more of a difficult struggle for having your ACL done. So we don't look at age so much as we look at your overall knee health and when we make these decisions about would an ACL surgery be beneficial or not. The idea behind the theme here is that once upon a time, this was sort of looked at as a young person surgery. Not everyone needs an ACL. There's a little bit more of an age cutoff, things like that. And that's back, again, that's an old way of thinking. And what they've shown throughout the years is that back in the 90s, only about half of the males and about a third of females had their ACLs fixed. And as you go through the decades, 95, 99, that shot up to 60s, and then 2/3, and now we're into about a quarter of patients, or 3/4 of patients have their ACLs fixed now. So you can see that the trend has gone to more and more people are having these done because the outcomes with surgery have gotten better and better, and people have done, been able to get back to their sport and do stuff they want to do with surgery. So the trend is increasingly towards surgery because the outcomes have shown to be better with surgery. All right, so we're not going to talk too much about surgery technique. That's a very individual conversation with the surgeon you're having surgery with. And so a little bit outside the scope of this talk, more than happy to talk about it afterwards if anyone has any particular questions, but we're going to kind of gloss over surgery. You're asleep anyway. So surgery's done, you wake up, now what do you do? Okay? This is where all the fun stuff is. So these are the main questions we'll typically get after surgery. And these are the basic things. So how long are you going to be on pain medication? Typically about 2 weeks. All right, so most people come off after about 2 weeks. Some people tail off into the 6-week range. Very uncommon to go past 6 weeks. All right, how long are you on crutches? Again, usually 2 weeks is the magic mark there. Some people on to 3, but it cuts off very quickly after that. All right, getting back to school, kids go back to school 1, sometimes 2 weeks afterwards. Are typically off pain medication at that time, getting off their crutches so they can start handling going back to school. Going back to work, pretty much the same idea. Around 2 weeks is when people are going back to work as well. And then driving, this is probably the biggest question that I get, and it really depends. Is it your right leg or your left leg? So people with the left leg, getting back to driving quite a bit quicker. If it's your right leg, you're usually off of driving for closer 4 to 6 weeks. Because you have to imagine that you have to be not only able to drive, but able to drive safely. So if you have to hit those brakes, you need your right leg to really be working. So it takes a little bit longer to get there. So once you're out of that acute initial period after surgery, you're back to driving, back to work, things like that. Ideally, we get physical therapy started within a week or so of surgery, which is highly recommended by the Academy as well. That one's pretty basic recommendation right there. The variability of physical therapy is kind of a little bit of the wild, wild west at the moment. So there's no standardized protocol between hospitals or between practices what you should do for therapy. So this is an idea where, and I again apologize, it's blurry, but something as simple as a stationary bike, some people get on it right away. Some people wait 8 weeks or 2 months before they get people on a stationary bike. The average is around 2 weeks, but again, there's a wide range there. Getting back to walking, anywhere between right away to 10 weeks. Doing the elliptical, stair climb, or swimming, between a month and 4 months. So there's a wide range, and there's only about 30 published online protocols with academic hospitals out of about 130 hospitals. So the majority of them don't have a published guideline. The information's not available. And so really depending on where you go, your physical therapy rehab can be accelerated, it can be slow. And so that's certainly something, if you have to undergo this whole ordeal, that you want to get an idea of ahead of time. What am I getting into with the post-op protocol? What's our game plan here? Because again, there's a big variation. And one thing also with return to sports, some people are getting back after about 4 months. Some people are getting back after 2 years. So a big spread on game plans here. So there's something called the Moon Group, which is the basically multi-center orthopedic outcome network, where a lot of surgeons got together and decided to track their outcomes and see how are our patients actually doing. Because most of the time with surgery, you do your surgery, give yourself a high five, and you'll see the patient back in 3 months and don't have to worry about it. Everyone does great until you actually look at your data and how well are people really doing, okay? And that was the idea behind this. And so they came up with some recommendations, and the big takeaway recommendation that we really are getting into nowadays, it's not timeline based. You don't say, at 2 weeks we do this, at 4 weeks we do that, at 3 months we do this. It's really, we progress you when you're ready. So we look at things like how much swelling is in your knee, how's your range of motion, how is your strength, are we ready to get you into running, are we ready to get you to doing lateral motion and balance and things like that. And if your knee is really swollen and very stiff, you may have to wait a little bit longer than the next person to get back to that, or to get to the next stage of what you want to do. So other recommendations, early weight bearing and motion. This has been shown initially. This was not something that was recommended. People were non-weight bearing for multiple weeks. Everyone was stiff, had peripatellar pain. So your kneecap pain was pretty significant. They started doing early range of motion. Everyone fared much, much better. And so that was something that we really emphasize now, again, that early weight bearing and early range of motion. We typically want people off crutches and 0 to 120 degrees within the first 4 to 6 weeks after a surgery. Maybe. The CPM, the continuous passive motion machine, that little machine that moves your knee for you, it looks a little bit like this, maybe. Next slide. There we go. Looks like this. This is shown to not have any difference in outcome at the 1 year mark. It may make you feel a little bit better in the beginning, but at 1 year does not make a difference in return to sport and other metrics, so insurance has stopped paying for it. So they are still offered to certain people who would like to do it, but by and large, it's not standard protocol to give these anymore, just because they don't improve outcomes. And they weigh a lot, so to set it up in your house takes like 2 moving people to do it. The E-stim machine, so the little electrodes that zap your leg, that feel very nice. People tend to like those. Those are helpful, okay? Not necessarily required, but they can be helpful, not to the extent where they've shown a definitive benefit for people, but it is pretty common practice that we use them. They look a little bit like this. They're also useful for pets. So yeah, they can make, they feel good. They tend to help get swelling out of the leg and get your femur and your quad muscles working a little bit better. Neuromuscular training. So this is something that can be for post-ACL rehab and actually a little bit of prehab or ACL prevention. We'll talk about this a little bit more at the end of the talk. But this is something that's very important because you do need to really focus on training your leg to not only start to get to work again, but you want to protect that ACL reconstruction that you've had. And so this is something that's heavily emphasized, that you want to go through surgery once, we want to do surgery once. And so getting your leg where it's healthy and in a good position where you're not going to have a repeat injury, that's the most important thing we really want to focus on with our outcomes. Accelerated rehab. So the big pressure is always, how can I get better, faster, stronger, more quickly, okay? Old thinking was that it takes at least a year to get back into your sport. Now we're getting athletes back around the 6-month mark. They started dipping under 6 months, and that's a little bit too quick. And so the rate of repeat injuries starts to go up once you go under 6 months. So 6 months has sort of been the benchmark where we are nowadays. People typically are waiting 6 months. And some athletes are taking longer. So Garoppolo, I think, was around 8 months. Wentz was a little bit more than that. So looking at these quarterbacks getting back into high competitive athletics, you're looking at the more than half a year to get back to doing what you want to do. All right, so what do we do up at the lake? What do we do, in this area for getting people back to doing things, okay? This is where we get our physical therapists involved. And we have our own ACL rehab protocol, and this is basically based off of what the U.S. ski team recommends. So when we're treating U.S. athletes, this is a collaborative, developed, protocol. And again, the main goal behind all this, all right, where we start up here, we do what's called prehab. So this is getting in to seeing the therapist before surgery, lay out the game plan, what can you expect, where are we trying to go, and then, early post-op, immediate post-op, and, getting back to getting on the snow. All right, and it's laid out this, and the one thing I really want to point out is there's no timeline associated with this, okay? There is no 2 weeks next, 2 weeks next. It's you get to the next stage when you're ready for the next stage, and that's very important, all right? You can give approximate timelines. This is typically 2 weeks, this is typically 4 weeks, but there is no definitive graduation to the next step. All right, so these next few slides are pretty busy, and I just want to kind of highlight a few things about what we do and what our game plan is. So this is the prehab part of it. So prehab, and again, pretty blurry. Sorry. Just trust me what I'm saying. So prehab is right in here. So really, orientation, meet your therapist, make sure that you like them. If you don't like your therapist, you're not going to hurt their feelings if you want to see someone else. They're all professionals, okay? And so we do get, every now and again, people just don't click. They're not listening to you. You're not listening to them. And switching up to see someone else, it's all about getting you better. So you're not hurting feelings by asking to see someone else. But that is important that you guys are going to be working together quite a bit. So meshing, that is important. Right after surgery, we really want to protect what we did. So we put a new ACL graft in there, and that thing needs to be protected for at least the first 6 to 8 weeks. So we really are very gentle. It's very passive motion. You're working on, getting the leg working a little bit more, things like that, but you're not really testing that ligament out quite yet. Again, very busy slide there. This is the next stage, and it's really you're working on your range of motion. You're working on, did I highlight something here? There we go. Range of motion, getting back to 0 to 120 degrees. And we like to see that in the first 6 weeks or so. If you don't get your range of motion back early, you're going to get it back late, which sounds pretty basic. But the longer you wait to get your motion going, the harder it's going to be. So it's better to get that started early than to wait. So then this is just more of the same. So you're getting your motion going, you're getting off your crutches, you're getting, strength. You start emphasizing more on strengthening. As that graft starts to incorporate into you, then you can start testing it more and more and more. We don't have to be as protective, okay? And so getting out of this early phase here is you want to have that good range of motion. You want to start getting good strength. You want to get that swelling out of the leg and out of the knee. Okay, and then once we start getting into, month 2, month 3, that's when we start getting into things like jogging and really start, working on strengthening. Because at this point, your range of motion should be pretty well established at that point, okay? And importantly, in this part where we start getting that, activity should be pain-free and that swelling should be gone. If you start having swelling, we start backing things up a little bit more. All right, so we're getting in the month 4, and this is where we start to really test the ligament out. We start doing side-to-side motion, twisting, balance, things like that. So your knee is really starting to get tested. That graft is incorporating, and so the idea is that you want this knee to start to feel like your knee again. Okay, there's a different graft or there's a different ACL in there, and you want to become more and more familiar with it, what my knee can handle, what it needs to continue to work on. And that's the idea behind this. So we start working on pivoting, shifting, sport-related activities, but in a very controlled environment. So there's no other athletes around, no one's going to bump into you, things like that. It's very safe, very controlled. All right, it's kind of getting that muscle memory back into play. And getting back on snow is something where if you're in a controlled environment, you can behave yourself and stay out of the park, start testing things like that. Okay, so here we start getting into the 6-month mark, and once we get to the 6-month mark, when we feel that you're ready, then we release you back into the wild, okay? And so when can I get back to doing what I want to do? When do we get you back to sports, all right? So we've hit that 6-month protocol, and you're about ready to get there, okay? So what do? We test you, all right? So basically, this is the midterm exam that everyone is looking forward to. And the idea is that we want to see how your leg is comparing to its baseline, which is your uninjured leg. All right, and the key number is we want it to be about 93% of the other leg. All right, and there's a bunch of parameters, and I'm going to go through a lot of the stuff that we do here. So number 1 is measuring. Okay, so we measure, is your quad back to the size of the other quad? Is your knee back to the same size? Is your calf back to the same size? Okay, so basically very easy, take a tape measure and measure everything. This is kind of what we're going for, okay? So nice, strong muscles everywhere. This is a very busy slide right here, but same idea. So we're looking at your squat, lunges, lateral lunges, single leg squats. So again, it's very easy. Compare the left side to the right side. So it's a little, doesn't feel quite fair to your operative leg because it's got the non-operative leg that basically feels like it's studied for the test because it hasn't really had the rehab at all. So it's a pretty high standard we're comparing it to. This is what we call a wide balance test. And what we're looking at is how your one leg compares to the other. And to help us figure out what this is, here's Travis Ganong, who's going to go over what a Y test looks like. You play this clip, please. So this is forward, back to the left, and then back to the right. And you can imagine, yeah.
If you can hold a glass of wine.
Yeah. So you can imagine if you're doing that on one leg, and that is his operative leg. If you do it on one side, they got to do it on the other side. And you add up each of those numbers and you compare them. Very easy way to compare. How's your balance on one side versus the other?
So his injured leg is his right leg?
I'm sorry?
His injured leg, the one you operated on?
I actually have to backtrack. He actually has had surgery on both of his legs. So, yeah, so they're both his operative leg. So isometric push. So the same idea. So we have force plates, and a force plate is a little square, basically a scale, and it can measure. You have two of them, so one for each leg, and you can kind of get an idea of how much weight you're putting on each side. So we'll do both legs and one leg, and then force plates. I think this next one we got another video of Ganong here. Okay, let's play that one, please. So those are force plates down there. So very simple takeoff and land, all right? And then what we can do is we can take a look at this fancy computer and get an idea of how one side is doing to the other side, okay? And you want to see, again, you're looking for that 93%. All right, so force plates are there. Let me think here. So this might be pretty similar. Let me see what he does on this one. Similar idea. Okay, this is more of a push-off one. And then going from there, so let's see the next one, counter movement. So this is one where you stand on a box, jump off the box, and then jump back up. Same idea, use the force plates. We can see how much weight you're putting on each leg. All right, so that gives us a lot of information, how much strength you have in the leg, and really how much are you trusting that leg. Because if you jump off the box and put all your weight on your non-op side, you're not trusting your surgical leg, you're not ready to go back in the sports, because if you try to guard your leg and not use it, you're gonna get hurt. So this gives...
From the box to the square spot?
Yeah. So this is multiple different pictures. I think they may have moved the box a little bit, because you typically don't jump all the way like that. You typically, it sits usually right around here. So that's a little, that is a big jump. That's not usually how I do it, because it's more dropping down than jumping forward that we're trying to test. The opto jump, opto is just a very fancy video surveillance system that we use, and it just uses lasers and it can kind of see what you're doing. So this is a little bit more video analysis that we use. And I think we've got a video. That's a single leg jump right there. You can play that one. So the idea behind this is now you can't hide your leg, okay? We'll typically do double leg things first, and if you graduate off the double leg, then we'll get you into single leg. If your single leg isn't strong, you can imagine that you're going to have a lot of wobbling in there. So you have to graduate out of doing double leg things before we get you into single leg, because it certainly puts your leg a little bit more at risk. And I think the next one, we should have an opto jump here. Yep, I might have skipped over it. Or there, we took it out. But again, it's video analysis, so you're looking at how someone's moving, how their leg is behaving, okay? So you graduate out of that, and now it's getting back to doing sports, which maybe. Okay, so you're getting back into doing what you want to do, which the big question is, am I going to get hurt again? Okay, so what puts you at risk? Okay, so being young and dumb typically puts you at risk. Higher activity level, and when we talk about graft type for younger patients, if they have allograft or cadaver tissue, that tends to put them a little bit higher risk. That's typically only if you're under the age of about 23 or so. Higher activity level there. I don't know if I'm pointing this at the right spot up there. Okay, so getting back in the sports, some sports are more risky for your ACL than others. Okay, so typically football, basketball, soccer tend to be the highest risk, with football really being the risky one there, that people are diving at your knees. So those are pretty high risk of re-injury there. Skiing is certainly on the lower side, but there's such a variability in skiing ability, aggressiveness, things like that. It's a pretty tough one to study. Okay, so when you're up and you are skiing, what's the best way to protect your ACL and keep it happy? So for skiers, what are we going to do? So the next big thing is, does it need a brace or does it not need a brace? ACL braces for recovery from ACLs have shown not to prevent re-injury, except one study for skiing showed that that was protective. Again, I do apologize, it's blurry, but so non-brace skiers versus brace skiers. Non-braced, 51 injuries out of 500. Brace skiers, 10 injuries out of about 200, so about half the rate of the injury. And the main comparison, even though the injury rate was about half, the percent that required a repeat ACL surgery if you had a brace on was 0, and 22 people of those that weren't wearing a brace had to have a repeat ACL injury. So the brace may not prevent an injury, but it was shown to prevent a repeat ACL tear. So that's the takeaway from that point. So for skiing, braces do help. Again, this is one study, so how much stock to put in it, little bit variable, but we typically will brace people for the first year or so after their surgery. Gives them a little bit more comfortable and confidence with going up on the slopes. Same thing, so getting back, if you're an X Games skier or snowboarder, getting back to it. These guys all did fairly well. So 15 skiers and 10 snowboarders had to undergo. Almost all of them got back to skiing or competing in X Games, about 80%. And they also, pre-ACL tear, 22 medals. After ACL, 24 medals. So they didn't have a drop in performance. And snowboarders actually went from 7 medals to 19. So snowboarders did better after they had their ACL injuries. So ACL surgery does not just get you back to doing the sports you want to do, but can get you back to a high functional level of what you want to do. All right, so talked about what your ACL does, how you injured it, how you get back to doing stuff you want to do, risks of re-injuring it. And really the goal is to make this whole talk obsolete. How do you stop from getting in the office in the first place? Okay, so how do we prevent that? All right, and back to what we talked about before, that neuromuscular training, okay? And so the idea that you can train your muscles to actually help prevent ACL injuries. And the main goal is you want to, if you're trying to stop, slow down, or change direction, you want to fire your quad and fire your hamstring simultaneously, and that keeps your leg in a good neutral position without moving your tibia one way or the other. And that can be taught and that can be learned, okay? So there's a lot of programs. This is very in vogue at the moment that we're doing this preventative ACL neuromuscular training, lots of buzzwords that go along with that, okay? There's many, many programs out there. They do have a proven effectiveness. So you can get an idea that if we're doing analysis, this leg in this turned in position, that puts your ACL at risk, okay? There's a risk of that same idea when you're skiing that leg gets turned in. You can see where this foot is positioned, that leg is getting turned in. Same thing with running. If your knee starts going across the midline there, that's putting it at risk. This is just something, if you look online, Soccer Gal Pal or Soccer Girl Problems, she goes over good technique, straight up and down, bad technique. And it's very good that thumbs up, thumbs down, very binary, good, bad. This is a doctor who published a lot of findings on how to do this. Females are more at risk for ACL injuries, and so this is a big emphasis on keeping females out of the office. Same idea here, straight up, straight down, knees start turning in like that video from, or that picture from before. You see what her feet are doing. To get your knee to look like this, your feet typically start to turn in a little bit. And again, you get that twisting rotation across the knee, putting your ACL at risk. Same idea there. Green is good, red is bad. Legs, when they start to cross in, puts it at risk. Same thing here with the single leg. And this is one additional exercise that's shown to be helpful. This is actually working your hamstrings. If you imagine you're doing a dip up and down, you want to keep your back straight and good posture right there. So one more thing to add into it. All right, and we're almost done, so I'm going to wrap this up. So again, in summary, the ACL doesn't just keep your leg from going forward and backward, it also helps control rotation across your leg. Typically, this is a non-contact injury, so if you have an injury with an ACL, quite often you can't really blame anybody else. Not everyone needs surgery, and so that is a very personal decision about whether you want to undergo a procedure or not. The trend is going more towards surgery, but again, there's a very significant number of people who do not have surgery. If you do have surgery or not surgery, physical therapy is going to play a role in getting you back to doing the stuff you want to do. All right, this is not a career-ending injury. This is not what it was 30, 40 years ago. Most people do get back to doing what they want to do. All right, and our goal as orthopedic surgeons is to get you back to doing the stuff you want to do. If your big goal today is to get from the couch to the fridge and back, you don't need to undergo a surgery. This is designed to get you back outdoors and get you back to doing stuff that you want to do. And that's our goal for everybody. So thank you. Thanks for coming.